Okay, so let's talk about that. Delinda Brown, Hope Hospice. Let's talk about the difficult part of being in the hospice business. How do you manage it all?
So definitely balance and making sure I do things at home and after hours to let some of the empathy feelings go from talking to families and guiding families. And sometimes we take on that emotion from them as well. It's a difficult process.
So I used Hope Hospice services 3 times.
Oh, wow.
For my mother, my grandfather, and my grandmother. What is different about you guys is a lot of the outside family supports. And what I especially liked was the Camp Hope. I sent my daughter, gosh, my daughter must have been like 11 or 12. And I sent her to Camp Hope. So I really see the holistic approach in supporting the entire family. Now, does Hope Hospice also do that for their employees? Do you guys have a soft place to land?
I think it's everybody. We have each other, definitely. And we've talked about that plenty of times. I'm thankful for our team, and we definitely have each other to vent to, talk to, get through moments, get through times, and just our families. And just like with me, I try to go hiking. I try to take care of myself so I can take care of others. That's a big thing, a big piece of it.
The 2 things that I did, because so when my mother died, I immediately got thrown into the caregiver role overnight. And right at that same time, I had Hope Hospice involved. And then I joined P2P because I was like, I'm going to lose my mind. And not only that, what I could say was really supportive of Joy was my nurse. Does Joy still work there?
She doesn't. She works for another organization, but I know Joy from a former life from skilled nursing.
She taught me how to use a bed sheet to pull and reambulate and all of that, how to use a gait belt.
We still do a lot of that education, and that's why I'm happy to be in my role, because since I was a nursing assistant for 15 years, I did all of those moving transfers, all the pulling. If you don't know
what you're doing, and I had no idea.
And that's how, honestly, I got into hospice. It was because I was dealing with my dad's illness. I lost my dad 5 years ago, and my dad was the first one on hospice in my family. I was working in home care at the time, but even navigating my parents in a different state, I signed them up for caregiving services because my mom was experiencing burnout. And then even when she was going through things while my dad was on hospice, she was calling me. What do I do? Do I give this? Do I not? What does hospice provide? How do things work? And there's so many people that had no idea how things work. And that's why my role now, educating these families on what to do, what to ask for, what to say, what we provide, and then also letting them know that it's a free covered service. The sense of relief that comes over some of these families, like, oh, someone's going to come in and help us. Someone's going to come in and provide that piece. So it's just been a blessing to help educate families as well with all the past knowledge that I have. Like I said, Joy and I actually worked in a trach and ventilator unit at a local skilled nursing. And so we learned so much in that unit.
She was incredible. And I think a lot of families, they have this perception of hospice is, okay, it is end-of-life care, right? Medicare is going to pay for it because it's end-of-life care. There has to be some qualifications. But I feel like families wait too long to tap into this benefit. And for my experience directly dealing with Hope Hospice was, it not only was mentally, emotionally, yes, I had the nurse, yes, I had the CNA, but I also had an entire team to educate me on this journey because I had no idea what I'm doing. So let's talk about a lot of the stuff that you guys do when you're bringing in services to the family.
Yeah, it starts honestly with my role with being in outreach, with me having some of that knowledge up front. So a lot of times we're the first ones to speak to those families. So I'm always listening for those, I call them kind of trigger words, caregiving situations or living environments, things like that, that I know may be something that may come up for our social workers. And if it's something that I can help them navigate right there, we start the ball right there. If it's something that I know that they're going to need soon after admission, we alert our social work team. And so everybody in our team is aware starting day one kind of with things, so that if things need to be put on earlier for families, they're already aware. So we do a whole team approach. And our communication is very good in that as well. So that, like I said, if I hear these words in the beginning, I'm already like, hey, they're going to need the support, or I'm already providing those resources for them right there in the beginning. And then comes our admission nurse, who's there to educate that family, be that first hands-on. Yeah. And again,
who was that, Victoria?
Team. Yeah.
Okay. So
but I've got a couple of them.
My goodness. She came into my life when I was going through my whole journey. My mom had just passed. I had taken over full-time role with both grandparents. One had renal failure, one had Alzheimer's. Right. And I lived 5 houses down. We all lived super close. So I thought, I'll be able to manage this. I quit my job, did all that. And then after my grandfather died, Victoria came to me and she said, Christine, you don't have to take this on. You know that, right? She gave me the mental, emotional permission to say, you know what? I did. I did what most families do. I promise I'm never going to put grandma in a nursing home until I know Victoria's seen it on my face. I was spent. I was burning at both ends. I'm surprised my marriage lasted during that time. Yeah. I hadn't, when you're in it, you don't see it, but she's seen it and she was like, I'm giving you permission, Christine. I know you need to hear from someone, and I did.
And that really helps with our staff, just even acknowledging and knowing those signs. Like I see it all the time, where it's the 80-year-old spouse trying to take care of the 80-year-old husband, and it's like, you can't do this by yourself. We're here to help you. Please take this help. Please let us help you. And if it's not me directly, it's my nurses, or like I said, our social workers, because a lot of times they come in, notice the caregiving situation is on tip of burnout. So they'll suggest caregiving or placement or whatever. And having that knowledge on how things work, how insurances work, helps those families navigate. Because when you're going through it, you're not even thinking of those things. The last thing I'm going to do
is make a phone call and try to figure out a plan, a policy. And I tap into what forget it.
So if we can help you offload some of that, or at least point you in the correct directions, get you in front of the correct people, we're always trying to gain that knowledge as well, me and my whole team. And all of us have been in healthcare for a long time as well. So we share that knowledge. If it's not me, I can usually call someone on my team and say, hey, do you know this resource? So I'm not leaving this family hanging with nothing.
What are some of those signs that you see for caregiver burnout? What are some of those? Let's talk about that, because I feel like if families would tap into this resource a little earlier, they would get a little respite mentally, emotionally.
It's usually families that have been providing care. Usually by the time a lot of people get that 6 months or less diagnosis, they've been going through something for either years or at least a year or 6 months already, with hospital visits and back and forth and a lot. So by the time we do have them on service, they just physically look tired, number one, a lot of people. And then, also it's very emotional to place someone on services. So you'll see them be emotional. And so a lot of times emotional and physical drain, you can just see it. Or they'll start to ask a ton of questions. And then you already know they're on a mental overload of, where are they going to go? What's going to happen? What's next? So even myself at those first meetings with those families, I let them tell me everything. That's my approach with families. Can you tell me a little bit about what's going on, while I'm feverishly making notes of everything I'm hearing? Okay, you're going to need caregiving support. You're going to need this. You're going to need that. A lot of times they're worried about the equipment and those things. And so when I tell them, we're bringing those things in. Oh, I've been looking for a wheelchair for months, or we've been trying to figure out how to get a hospital bed
or a shower.
And when I tell them, no worries, we've got that. We can have that delivered and it'll be there. And this is what's going to happen. I can see them kind of release that, like you said, that kind of release of, okay, I can breathe. I can sometimes even more anxiety, because now it's all these steps they have to do. And it's, but we're here. Call me, text me, we're here.
My mind was blown when Joy was like, oh, no, don't worry. Especially when my grandmother's bedridden and she had this blow up shower,
wash her hair.
I was like, what? My mind is blown.
We worked in that trach and ventilator unit for a long time, and where all of our patients were bedbound. So we learned all the skills and the tips. And so again, that just comes down to sharing it with the families. And I always try to keep in my mind, and also just let all my staff know, we can't treat them like they've been through this before. Even though it's our 100th, 500th time, this may be their first rodeo, first experience. So a lot of people don't know what to ask for that they don't know. And I've spent time with families showing them how to fold a flat sheet to make a pull sheet, and that light bulb that goes off like, oh, that's so much easier.
Yeah.
Yes, let me show you how to change a bed-bound person's brief and things like that.
Yeah.
Because families are just overwhelmed even thinking of that piece. While some are been doing it for a while, and maybe that's not it. Maybe it's medications or other education that they may need as the regimen may change or things like that. So it always depends on the family, but it's just a wide variety who have no idea how hospice works, how helpful we can be. And I hear it time and time again. I wish I would have called earlier. I wish I would have started 6 months ago when doctor actually suggested, or I wish I would have did this, because now I've got the help I needed, or at least been pointed in the right directions. That help with paperwork, or social workers help with Medi-Cal paperwork and help with leave paperwork and things like that, just sitting with families. Because they just don't even have time.
To even want to do any of that. It's too much. So what's the difference when you're explaining to families between palliative care and hospice care? Because I know families don't want to hear the H word. So how do we get your supportive services through the door without saying the H word?
And I like to be honest with families to exactly what hospice is. I don't like for them to be surprised when we then let them know certain things aren't covered. So I try to have a very transparent and clear conversation with my families on, if you still want to continue these things, it may be more appropriate for palliative services. So really the difference with palliative and hospice is palliative is going to be more that Monday through Friday, 9 to 5 kind of bridge between your specialist and your physicians to talk to them and tie those circles together, but also give that support. That's a little bit of an additional layer on top of the physician. And you also get to
keep your current doctor, plus you guys will come alongside.
Correct, for any palliative care. So Hope does not do palliative care at this time. It is something that we will be getting started. It will be getting started soon. But right now at this time, but I do educate our families. A lot of our patients are Kaiser patients and also Stanford patients. And so they do have their own palliative programs as well as John Muir. So I'll usually let them know more about that palliative piece, or at least make sure that they speak to a palliative physician before maybe going on hospice. Just so that physician can give them their options and give them more in-depth options on their treatment. Because a lot of times it's continuing chemo or continuing dialysis, and families aren't ready to give that piece up. So being on palliative allows you to continue that treatment, but also get that additional layer that's not quite hospice, which we're 24 hours a day, 7 days a week. You call us at 1 a.m., we come out. Palliative is not that way, but it is that additional layer. So sometimes that's an option for families.
And so do families have to get a referral from their primary, or can they just call you themselves? How does it work to engage?
So what we do, it's family driven and it's or patient driven. But families definitely reach out to us before we have a physician's order so we can help them navigate that. But we do need a physician's order. But like I said, we can help request, help do what we need to do to help those families. Because sometimes that as well, letting them know, hey, you have to do this and you have to do that. Or they haven't been to the
doctor in 7 years.
Right. And that was tricky coming out of COVID. And there's ways with that as well that we can help navigate that. At least by now, someone's at least had a video visit, but that even counts if we need to do that as well. But we help, again, with that navigation from the beginning, because we do get those families. Now, how do I get this started? Okay, you told me about it. Now, what do I do? Okay, depending on the healthcare system, we all know how each one works. So we definitely tell them to reach out to their PCP or specialist, because you can also reach out to your oncologist, cardiologist as well. It doesn't have to be the primary. Any of your physicians can do a referral.
And there's so either the qualifying conditions are typically what, dementia?
Anything that's terminal, 6 months or less prognosis from the physician.
Dementia can be forever.
Dementia is a tricky one, but our nurses are really qualified in determining what those qualifying standards are. And we always tell families, we get the referral, but it's always up to that initial assessment from our nurse to make sure that the patient qualifies. We really try to stick to those qualifiers, and they're really good at it too as well. But dementia can be the trickiest one. A lot of people automatically think cancer, but it's also things like congestive heart failure, COPD, things like that. We get some neurological diseases, ALS. So there are others that are also hospice appropriate, but basically anything that's a terminal illness that does not have any, if it progresses in its natural course, it's a 6 months or less prognosis.
And we can edit this if whatever. But when we got my grandfather qualified, he was still doing dialysis, and we got him qualified on his cardiac stuff.
Yeah, sometimes if it's not tied to the diagnosis, it can be used as a palliative measure because it still provides that comfort. And so different situations, different insurances have different rules to that. But I actually was speaking to the VA yesterday and learned that you could still do that with the VA because it's billed through their insurance instead of Medicare. And just, again, learning different things as I go, that some of these things still can be continued depending on the diagnosis.
Yeah. And I think we had services for, well over a year because with my grandfather, he was like, I'm done, not going back to the dialysis because those were some hard days.
Yeah.
Those were really hard days. I would sit in there with him just to advocate on his behalf if they were pulling too much fluid off or whatever those fancy machines do. He was getting cramping in his legs. So I'd be like, excuse me, right here, chair number 5. So I had to be that granddaughter, right?
And everybody doesn't have that advocate for them.
Yeah, gosh. I hope that my kids have seen how I have handled situations in my family. I was just out of town in Arizona at a conference, and my grandmother, my mother's mother, who lives here in Pleasanton, ended up in Valley Care.
Oh my.
She had, it was like a gastritis thing. And I was like, lady, you cannot go to the hospital if I'm out of state. But my daughter showed up. So I was like, okay, good. So I'm doing something right. Because my 18-year-old gave up part of her Saturday to go sit with grandma. I was like,
I think that's just, I always tease with my kids because they grew up in the nursing homes. And so I've told them also my wants and what I don't want. And sometimes they overhear some conversations and I really let them know. I was like, they know early what I'm going to want and what I don't want, whatever time. And that's also important too. And I know I work in this line of work, but the conversation in our house is easy and sometimes even funny.
But
my kids know my wants. So
I have my pulse. My pulse is already, I had it signed. I do not, if I have a stroke or something like that, I do not want any life-saving measures. Let me go. And also, I don't want to.
That ties it back to
burden on my family.
Yeah, that ties it back to working in that trach and ventilator unit. I had a 99-year-old and he was full code and on dialysis daily. And that actually helped me spark the conversation with my parents because when I got off work that day, because I was in my 20s, and I got off work that day and I said, hey, you're 99 and you have me listed as your medical POA. I'm not putting you on a ventilator. Like, we're not doing dialysis and ventilator at 99, unless that is what you want. But can we have this conversation right now? What are your wants? What don't you want? And then also, before I had my children, Kaiser actually had me fill out an advance directive. And so that sparked a conversation with my husband. When I let him know what measures I wanted. And this is in my 20s.
Wow.
And some people don't have this conversation at all. So it's just making it normal conversation in the household. It's normal conversation with my kids. They know they were running around that ventilator unit when they were little kids and they've seen that life. So it's not an odd conversation in our home. But we know it's not a common conversation in others. And so we also want to encourage people to talk about it more before you get to hospice. It really makes a difference. We see the differences in those families that have had those conversations, had those talks, compared to the families that have not. It's a very different experience and also usually more peaceful and calm in the ones that the families have had those discussions. And
I do think families do have that perception of, and I get it, it's 6 months or less to live, but gosh, if you can get in there earlier, because I don't think families understand, like, you're going to have a nurse that's going to come, like a registered nurse that's going to come to your house and support you, look over things, make sure everything's in order. If you need anything else, incontinence supplies are provided, as well as all of the DME equipment, your hospital bed, your commode, your oxygen,
everything.
And I had a volunteer call me every Friday. Christine, is there anything do you need me to pick up medication? Is there anything that I can do for you? I was like, I just, can you just hear me 5 or 2 minutes?
And they can do that too. And you get the social worker and our spiritual care and you get the home health aide because sometimes they are paying for that private duty caregiver as well. And so that also gives that private duty some help too, you know?
But even once you're bedridden, and when I say we had the setup, single story house, we had that fancy little walk-in tub that you see on the TV, which is horrible. People don't get that. Once you can't move your legs, you can't close that door.
No.
So forget it.
No. Yeah.
But the skilled professionals came in and said,
Right.
hey, why don't you attach a little hose to the toilet?
Because usually we know all the little tricks, and families are like, oh, I didn't even know that exists.
Made my life easier.
And then with Amazon, I even tell family, hey, if you got Prime, it's there the next day. Like, these are the things that are going to make things easier. But again, you don't know what you don't know. And so having a team that does have some expertise, and a lot of us are 10, 15, 20 years in, we've seen the tips and tricks. We can help. And again, those families are usually so thankful.
Yeah.
And the 6 months or less is a misconception as well. Studies have shown that someone being on hospice usually does live longer because someone is managing those symptoms. We usually are able to bring more of that quality as well. Quality of life, not the in and out of the hospital, in and out of being poked, prodded and everything. We come to you. Like you said, we come to your home. A lot of people are just surprised with that. Because as mobility changes, that becomes an issue.
Forget it.
It really does get in those doctor's appointments, staying compliant with the medications and everything else, and gets confusing. A lot of people that go to their doctor's appointments and don't even know what the doctor told them to do. So when we say we come to you, that's usually a relief to families because they were already thinking, how do we get to this next doctor's appointment? How do we get them in and out of the car? Because sometimes that becomes so cumbersome. So to hear, we come to you wherever you call home, skilled nursing, assisted, boarding care, wherever you're at. We come to you, we provide everything, we show up, and it's covered. And it's free.
Right?
Because we often get that question. I've had people say to me, oh, before we continue talking, how much is this going to cost me? So when I say it's an included Medicare benefit, Medi-Cal benefit, and it's free to you, you're not going to get that bill afterwards saying you owe this amount. That's usually another sigh of relief. A lot of people don't start because they think it's a financial cost. So just educating the community. I try to talk about it all the time just so people have knowledge of what's out there and what's that free benefit.
And I love, especially when I know a family, complex health conditions, and they're going to be moving to a community. And maybe it's a community where I haven't placed somebody there in a while. And I always like to have it, whether it's a palliative service or a hospice service, like a second eyes on. Because you never know. It could be, there could be some low staffing issues, and you just want to make sure after 90 days, have they developed a rash? Is there skin intact? All those things. And guess what? You don't have to pay for that second eyes. And a social worker is going to call you and say, hey, I was just seen mom on Thursday. Here's what we're looking at.
And that's the question we get a lot of times is, how do you interact with the facility? And so I often explain that to families too, is just as you said, those extra eyes, that extra layer, that extra reporting in, that extra letting you know. That's also from a licensed nurse perspective as well. It's just that extra layer. That facility is still responsible for mom's care and her daily things, but we're that extra layer and support to the facility as well. Not just the patient, but if the facility is not sure what to do, they know they can give us a call and we can have someone there for them to help answer those questions as well.
And see, like, I've had a situation where the nurse of the buildings are pretty busy. They're really worried about medication management and making sure everything's good in terms of med passes, right?